or should I wait for your signal?
Just 2 minutes. Rishab wants me. And then...
Okay.
Or should I wait for your signal? So it's live now. Just a minute.
Mm-hmm.
So good morning, sir. Welcome to the live lecture. Thank you for accepting the invitation. So we are now live. Now I would like to invite Dr. Naresh, our head of the department, to welcome you for this guest lecture on Alzheimer's dementia.
Very good morning to all. Thank you very much, Dr. Rishab, for being with us and delivering this very important talk. And again, it's pleasure and privilege to get you here because all the colleagues together. And yes, our residents are very much interested, and all of us eventually, to be with you for next 1 hour and to learn many of the clinical pulse of the topic of dementia. And thank you to you and all the people attending this lecture. Over to you, Dr. Rishab.
Thank you so much, Dr. Nabinani. It's an honor to be here this morning with all of you. So to be mindful of the time, I will straight away get to the talk. So let's see. It seems my screen sharing is disabled.
Not yet, sir.
So you'll be able to
now it's fine. Yeah. Let's see. Okay, so good morning, everybody. As you all have already heard from Dr. Kadiresan and Dr. Nabinani, my name is Rishab Gupta, and I'm a final-year fellow in behavioral neurology and neuropsychiatry at Brigham and Women's Hospital, which is an affiliate of Harvard Medical School in Boston, Massachusetts. And today I want to talk about something very important, and which is our bread and butter in behavioral neurology and neuropsychiatry, Alzheimer's disease. And I want to cover the most important things related to this topic, so that you guys can get a good handle on this disease after the talk. So first of all, the disclosures. I don't have any conflict of interest other than the fact that Dr. Kadiresan and I are good friends, and we were also colleagues at AIIMS New Delhi. And I will be briefly talking about off-label use of certain psychotropic medications, which are used to treat neuropsychiatric symptoms of Alzheimer's disease. And the learning objectives of this talk are to appreciate the significance of Alzheimer's disease from both clinical and public health standpoint, and to learn the algorithmic approach to diagnose it, and to learn the principles of treating Alzheimer's disease and its complications. Now, following is the outline of my talk. We'll start with introduction, epidemiology, stages of Alzheimer's disease, its diagnostic criteria, clinical presentation, neurobiology, and how we evaluate it in the clinic, and then how we manage it. Now, before I begin the talk, I want to highlight some of the popular myths and misconceptions about Alzheimer's disease, which are prevalent in the community throughout the world, actually. And unfortunately, even I used to believe in some of them as a medical student. So first of all, Alzheimer's disease does not equal Alzheimer's dementia. I mean, people can develop dementia because of Alzheimer's disease, but it does not automatically mean that everybody who has Alzheimer's disease has Alzheimer's dementia. And then people think that this is age-related cognitive decline, so nothing to worry about it, but that's not true. And then people think it does not really kill patients, but it does. That was the thing that I used to believe as a medical student. And I think it was actually taught to me. And then some people think that it's a death sentence, which actually is not true, because many patients continue to live healthy lives for several years despite the diagnosis. And then people think you have to establish memory loss to diagnose Alzheimer's disease, which again is not true. then people think only old adults can develop Alzheimer's disease, which again is untrue. And then people think it is always hereditary, which is also false. And then there are a lot of clinicians, researchers who think it's genetic testing can diagnose it, which again is incorrect. And then there are a whole host of companies which sell nutritional supplements claiming that it will prevent Alzheimer's disease, which is also incorrect. Now, before talking about Alzheimer's disease, I think it's very important for us to know what is dementia. And in 2011, National Institute on Aging in US, they gave criteria for all-cause dementia. So you can apply these criteria for any type of neurodegenerative disease or non-neurodegenerative disease causing dementia. So it is diagnosed when people develop cognitive or behavioral symptoms which interfere with their ability to function at their work or with their usual activities, which means instrumental activities of daily living, including managing their medications, their appointments, managing their finances, shopping, and then driving their car, which is very important for people in the US, as you guys may already be aware of. And then one needs to demonstrate a decline from previous level of functioning in the patient for them to entertain the diagnosis of dementia. And these symptoms should not be explained by delirium or underlying major psychiatric disorders like depression or psychosis. And then cognitive impairment can be diagnosed by adequate history taking and objective cognitive testing, which I'll talk about today. And then the cognitive or behavioral impairment needs to involve at least two domains. And there are several, so including poor ability or lack of ability to acquire or remember new information, impaired reasoning, impaired ability to make good decisions, impaired visuospatial functioning, impaired language functioning, which can manifest with difficulty with speaking, writing, reading, or changes in personality. So oftentimes, patients in the clinic will present with this particular kind of history, or the family members will tell you that the patient is asking questions repetitively or repeating conversations. They are misplacing their belongings. They're forgetting important events or appointments. They're getting lost while driving or while walking around neighborhoods. They may have difficulty recognizing faces. They may have difficulty using simple gadgets, which they were earlier proficient in. They may have difficulty wearing their clothes, and they may have word finding difficulties. They may have mood changes or personality changes. So these are the common ways by which dementia presents in the clinic. Now, this disease, Alzheimer's disease, was first described by a German psychiatrist, Alois Alzheimer, in 1906. And he was a good friend of Emil Kraepelin, the one who first described schizophrenia. It's a devastating neurodegenerative disease which disrupts cognition, psychological functioning, and biological functions, including sleep, appetite, and libido. And in late stages, it can also affect motor functions, thus it making patients bedbound. It also causes dysphagia. As a result, they may have difficulty eating and drinking water, and they may choke on what they eat, causing aspiration pneumonia, which is the major cause of death in these patients. And this disease can also cause seizures, which is an underappreciated finding. And the seizures, the incidence of seizures actually increases as the disease advances. And Alzheimer's disease, as I said, is the most common cause of dementia in both young adults and old adults. And by definition, we say young when they are less than 65 years of age. And despite being so common, it's highly underdiagnosed. And it comprises 60 to 80% of all dementia cases in the world. And its early onset type is not very common, seen in only less than 10% of the patients with Alzheimer's disease. Now, it's epidemiology. So its incidence increases progressively with rising age. Among people who are 65 or older, it's present in 11% of them, which is 1 in 9, which is very high. And then in the age group of 65 to 74, it's seen in around 5% people. And then in the age group of 75 to 84, its numbers increased by 3 times, so becomes almost 14%. And then among people who are 85 and above, it's seen in 1 in 3 of those of that subgroup. And in the US, it's estimated that there are 6.2 million people with Alzheimer's disease. And globally, 63% of patients with Alzheimer's disease live in low and middle income countries, including India and China. So as a result, it's extremely important for us to be aware of this. And India has estimated 5.29 million people with dementia currently. And this number is expected to double by 2035. So within just 14 years, which it's like an epidemic. And it's, as I said, it's underdiagnosed. So the cases of undetected dementia are estimated to be 61% in the world. So we need to do better in terms of screening and diagnosis. And what are its risk factors? Age is the biggest risk factor. And then ApoE4 genotype is another very significant risk factor, but it's very uncommon, this genotype in the population. And then female sex is a risk factor, but it's not very clear actually whether being a woman really increases the risk or not. I mean, in the epidemiological studies, it has been the case, but if you adjust for cardiovascular disease and other risk factors, sometimes in those studies, this significant diminishes. And there are vascular risk factors which increase the risk of Alzheimer's disease, like hypertension, hyperlipidemia, smoking, diabetes. Low socioeconomic status is another risk factor, and so is positive family history or Down syndrome. It's the 6th leading cause of death in the US. And on an average, a person with Alzheimer's dementia lives up for 4 to 8 years after their diagnosis. So it does kill. And then what are the stages of Alzheimer's disease? So apart from its most well-known presentation, which is dementia, it also has a mild cognitive impairment stage in which people do not have any problems in their functioning, but they have objective deficits in their cognitive functions. If you do a mini mental exam on them or a MOCA test on them. And there is another stage before mild cognitive impairment called subjective cognitive impairment, which is a preclinical stage where patients may complain of memory difficulties, attention difficulties, but if you test them on a cognitive exam, they do not seem to have any symptom, any difficulties, and their functioning remains fine. And then mild dementia is operationalized as people with dementia who have deficits in their instrumental activities of daily living. Moderate dementia is operationalized as people with deficits in their basic ADLs, which means difficulty with taking shower, changing their clothes, feeding themselves, moving around. And then there is severe dementia, in which people become completely dependent on their caregivers and are not able to do anything. And then among those who have mild cognitive impairment, 15% of them will develop dementia if you follow them up for 2 years. And then around 1/3 of them will develop dementia over a period of 5 years. However, there are certain subgroups of mild cognitive impairment which do not progress to dementia. And their proportion is unfortunately not really known. Now, how does this disease evolve over time? So there are certain biomarkers which have been developed over the years. And so they are known to appear, they become detectable much earlier, even before the patients present to the clinics. So the earliest biomarker known to be abnormal in Alzheimer's disease is amyloid beta protein. And that can be detected by using CSF studies or by doing an amyloid beta PET scan. And then the second biomarker to become abnormal is tau protein, which is a protein in the brain, is a marker of neuronal injury. And that can be detected by, again, CSF studies or using an FDG PET scan, which is designed to detect tau protein. And then later on, patients begin to show brain atrophy, which can be detected by MRI or abnormal metabolism on a PET scan. And then only after these changes have been happening for years, they tend to develop cognitive symptoms and present to the clinics. So it is estimated that the Alzheimer's disease begins around 20 years before the patient presents to your clinic. So it's extremely important to appreciate this finding. Now, how do we diagnose Alzheimer's disease? So again, NIA in 2011 revised the criteria which were used for almost 3 decades, and they basically describe 2 types of Alzheimer's disease dementia diagnosis based on their certainty. So the most certain you can get clinically is by saying that the patient has probable Alzheimer's disease, and for that you need to demonstrate that the patient has dementia, which I already talked about, how you can diagnose someone with dementia. And in addition, you need to demonstrate that the patient had an insidious onset of symptoms, which means they appeared over a period of months to years, not within days to weeks, because that would mean acute or subacute onset. And then you need to demonstrate a clear-cut history of worsening of cognition, either by talking to the patient or the caregiver, or by observing in the clinic longitudinally. And then the initial and the most prominent cognitive deficits, you can assess them on the examination that you can do bedside. And the most common presentation of Alzheimer's disease is amnestic presentation, where people have poor episodic memory, in which they have difficulty learning and recalling recently learned information. And for amnestic presentation, they also need to have another cognitive dysfunction in a different domain than memory. And I personally think that these criteria are actually not very scientific, because, as I said earlier, patients may have Alzheimer's disease without having dementia. And these criteria require patients to have dementia for them to be diagnosed with Alzheimer's disease. And there are other subtypes of Alzheimer's disease which have a non-amnestic presentation, including language variant, in which the most prominent deficit is in finding words in conversations. Along with that, they need to have another cognitive dysfunction in a different domain. Then the second subtype is visuospatial presentation, in which the most prominent deficits in the spatial cognition, in which people may have difficulty finding objects, difficulty recognizing faces, difficulty knowing what an object is, even though their vision is fine, and simultaneous agnosia, in which they miss forest for trees, proverbially, and alexia, in which they have difficulty reading, even though their vision is fine. And then there is executive presentation, where their reasoning gets impaired, their judgment becomes impaired, their personality may become degraded, they have difficulties problem solving. And apart from all these, you also need to rule out other causes of cognitive decline, which means any significant stroke, any other neurodegenerative diseases like dementia with Lewy bodies or frontotemporal dementia. You need to rule out any psychiatric disorders which can cause cognitive problems, any medical causes which can cause cognitive problems, or any medications which can cause cognitive deficits. So you need to rule all of that for you to diagnose someone with Alzheimer's disease dementia. Now, what are the typical MRI findings you see in various Alzheimer's disease syndromes? So in the top plate, it's typical Alzheimer's disease amnestic presentation. And as you can see in these arrows, white arrows, the hippocampi, which are present in the medial temporal lobes, they are atrophied. So you can see these black spaces. These indicate atrophy. And then among the non-amnestic presentations, the visuospatial variant is also known as parieto-occipital posterior cortical atrophy. In that, patients tend to have parieto-occipital atrophy. But if you look at their hippocampi, they seem absolutely fine. And then there is a language variant, which is called logopenic variant, of primary progressive aphasia, in which the main MRI abnormality is left temporoparietal atrophy, and their hippocampi again are normal, preserved. And then the fourth subtype is frontal dysexecutive Alzheimer disease, which presents with behavioral symptoms and personality changes. In that, the major MRI changes are frontal atrophy and anterior temporal atrophy. Again, hippocampi are preserved in these also. Now, then how do we diagnose somebody with possible Alzheimer's disease dementia, which is a less certain diagnosis than probable? So patients need to meet core clinical criteria of Alzheimer's disease for this category also, but they can have an atypical course, which means the symptom onset of symptoms could be sudden, or if you do not have sufficient details to say that the patient is declining over time, or if somebody has mixed presentation, which means they not only have Alzheimer's disease like pathology, but they also have vascular disease or another neurodegenerative disease, which again is a problem criteria because it's extremely common for patients with Alzheimer's disease to also have vascular brain disease and dementia with Lewy bodies, which I'll talk about very soon. Now, how does it present in the clinics? It's a very complex diagnosis, which we'll try to simplify today. For the problem, for example, for an amnestic syndrome, which is the most common type of Alzheimer's disease presentation, different types of neurodegenerative diseases can cause that presentation. Like Alzheimer's disease can cause it, hippocampal sclerosis, which is a type of neurodegenerative disease, can cause amnestic syndrome. Then gyrophilic brain disease can also cause that. Similarly, Alzheimer's disease can lead to different clinical presentations, which is amnestic syndrome or posterior cortical atrophy or logopenic primary progressive aphasia or frontal dysexecutive syndrome. So this disease has different presentations, different forms. And similarly, different diseases can have Alzheimer-like picture, confusing the clinicians and the patients alike. Now, another fact that I want you guys to remember is mixed neuropathology in the brain is extremely common in Alzheimer's disease. So patients not only have plaques and tangle pathology, they may also have vascular brain changes seen in 65% of them, Lewy bodies in around 42% of them, then late, which is limbic predominant age-related TDP-43 encephalopathy because of the deposition of TDP-43 protein in their brain seen in 35% of patients. Then our gyrophilic brain disease can be seen in almost more than half of the patients. And then cerebral amyloid angiopathy is very, very common in Alzheimer's disease brains. And then another problem with this disease, the correlation between clinical syndrome, neuroimaging, and neuropathology is imperfect. So not every patient who has amnestic presentation has a typical hippocampal atrophy, which I showed you a few slides ago. And also the degree of brain atrophy may not really correlate with clinical symptoms. So just because somebody's brain seems very shrunken does not mean that they have severe symptoms. They may be doing fine, and vice versa. And what are the neuropsychiatric symptoms in Alzheimer's disease? And these can be present even in MCI, actually, not only in dementia, but in MCI as well. And they are the core features. And they mainly include anxiety, depression, apathy, disinhibition, irritability, agitation, psychotic symptoms, which all of these are very, very important as us psychiatrists in working in the clinics to know. Psychotic symptoms typically consist of persecutory delusions, partition delusions, in which patients believe that somebody is entering their house through porous walls. They may have reduplicative paramnesia, where they believe that their house has been duplicated, and so the house where they live is not the same house anymore. Or it may happen for people around them, in which case it causes misidentification. They may also have auditory and visual hallucinations, and some patients may also have confabulation. And neuropsychiatric symptoms are seen in up to 50% of patients with MCI and up to 75% in dementia. And there is growing evidence to suggest that these neuropsychiatric symptoms independently predict conversion of mild cognitive impairment to dementia. And there are various hypotheses which have been put forward to explain the origin of neuropsychiatric symptoms. So it's believed that they could be primary manifestation of Alzheimer's disease process in the brain. Some people think they occur because of secondary disease process, which synergistically interacts with Alzheimer's disease neuropathology and increasing its risk further and progression. And some people think this is just a psychological response to cognitive changes. Like, for example, if somebody is losing their memory, they would obviously be depressed or anxious, or they may not worry about it at all. Now, a study was done in 1996 where they tried to see the natural history of Alzheimer's disease and how neuropsychiatric symptoms evolve in that. All these patients had autopsy proven Alzheimer's disease. And you can see, and 0 is the time when the Alzheimer's disease was diagnosed. So you can appreciate here that even 35 months before the diagnosis of dementia, the patients started having social withdrawal. And then later on, as the disease evolved, they developed depression, they developed paranoia, they developed sleep problems, anxiety, agitation, irritability, disinhibition, hallucinations, aggression. So it's a very important slide, and I would like you guys to take a good look at it. Okay, now neurobiology of Alzheimer's disease. So there are various hypotheses have been given to explain the underlying etiopathogenesis of this disease. So the most popular and most accepted is the amyloid cascade hypothesis, which came into being in 1980s when the amyloid A beta protein and tau proteins were first detected in patients with Alzheimer's disease. And then this theory started gaining traction in 1990s. So the underlying hypothesis is that amyloid precursor protein, which is gene for which is on chromosome 21, is cleaved by abnormal beta secretase and gamma secretase enzymes, which leads to formation of abnormal A beta peptides. And when these A beta peptides clump together, they lead to amyloid beta plaque formation in the extraneuronal space in the brain, which causes synaptic dysfunction, excitotoxicity, causing neuronal cell death. And then another popular hypothesis is tau hypothesis. Tau is a protein which is expressed in neurons. Its function is to stabilize microtubules and maintain cytoarchitecture of the neurons. So its hyperphosphorylation can cause accumulation of these tau proteins in the neurons, leading to formation of neurofibrillary tangles, which are hallmark of Alzheimer's disease. And these tangles then interact with essential cellular proteins, causing their dysfunction. And it is believed that this hyperphosphorylation occurs secondary to amyloid beta plaque formation, which initiate this process. But then there is increasing evidence to suggest that toxic tau formation can itself increase amyloid beta production via a feedback loop mechanism. And then one of the earliest hypotheses was cholinergic hypothesis, given in 1970s, where it was mainly put forward after noting that patients with Alzheimer's disease had cholinergic neuronal loss. And then it was also at that time believed that acetylcholine is involved in memory and learning. So people started using drugs which would increase cholinergic transmission in the brain. And as a result, we got donepezil and rivastigmine and galantamine like drugs. And then another hypothesis which is proposed is excitotoxicity, which is mediated by overstimulation of NMDA receptors in the brain, which leads to cholinergic neuronal loss. As a result, people started using memantine, which is an NMDA receptor antagonist, to reverse this process or halt this process and rescue the cholinergic neurons. And then there is vascular disease hypothesis, because it's well known that vascular risk factors can increase the risk of Alzheimer's disease, and also Alzheimer's disease brains have signature of vascular injury in the form of cerebral amyloid angiopathy, white matter hyperintensities on MRI, and also interestingly, hypertension starting in midlife is associated independently with neurofibrillary tangle development in the neurons. And then there is diabetes and hyperinsulinemia hypothesis. Some people believe that Alzheimer's disease is a type of diabetes, and they say that because in patients with Alzheimer's disease have insulin dysregulation in their brains, and the role of insulin in the brain is to control the tau phosphorylation and protect the brain against A beta accumulation by via insulin degrading enzymes, which becomes upgraded when there is increased insulin in the brain. But when there is insulin resistance in the periphery, which is commonly seen in diabetes, it actually downregulates the insulin uptake in the blood-brain barrier, which leads to downregulation of insulin degrading enzyme. And as a result, that enzyme is no longer able to regulate tau phosphorylation or degrade amyloid beta plaques. Therefore, and another mechanism proposed is that insulin signaling, when it reduces, it actually increases the activity of another enzyme called glycogen synthase kinase 3, which increases the formation of neurofibrillary tangles and cause neuronal damage. Now, another hypothesis was apolipoprotein gene, which is a risk factor, as I said earlier, for Alzheimer's disease, and it acts by increasing amyloid beta aggregation and reducing its clearance from the brain. And then there is, in 1990s, people noted in epidemiological studies that use of anti-inflammatory drugs may be protective against Alzheimer's disease, but those drug trials where they used NSAID drugs like aspirin, they didn't really pan out in the real world. Like those medication drug trials failed. However, inflammation remains an important target for drug discovery in Alzheimer's disease. And also, it's known that amyloid plaques and neurofibrillary tangles they cause damage through immune mechanisms. And then there is latest hypothesis, which is the viral hypothesis, where it is believed that herpes simplex virus 1 and 2 can trigger amyloid aggregation in the brains. And interestingly, their DNA has been seen in amyloid plaques in Alzheimer's disease. And herpes simplex 1 virus reactivation is associated with tau hyperphosphorylation and possibly tau propagation, which is one of the mechanisms of Alzheimer's disease. And in mouse models of Alzheimer's disease, using antiviral drugs can reduce amyloid beta and p-tau, phosphorylated tau accumulation, thus giving hope to treating Alzheimer's disease someday. Then what are the imaging, pathological, and genetic markers of genetic findings of underlying Alzheimer's disease? So one of the earliest, most consistent findings is mesial temporal lobe atrophy, which includes hippocampus and entorhinal cortex. And later on, patients develop medial, basal, lateral temporal atrophy and medial parietal atrophy. But eventually, as the disease progresses, the whole brain gets involved. And the hallmark for Alzheimer's disease pathology, as I already mentioned, is amyloid plaques and neurofibrillary tangles, causing synaptic dysfunction, neuronal death. Only 1% of Alzheimer's disease occurs because of single gene mutations inherited in an autosomal dominant fashion. So most of the Alzheimer's disease actually is polygenic complex disease whose genetic architecture is poorly understood. And the major genes associated with early onset Alzheimer's disease are three: amyloid precursor protein on chromosome 21, presenilin 1 on chromosome 14, and presenilin 2 on chromosome 1. And then the ApoE4 genotype also dramatically increases the risk of late onset Alzheimer's disease, not early, but late. And one copy of epsilon 4 TRP3 increase the risk of Alzheimer's disease by 3 times. And if you have 2 copies, your risk increases to 12 times. And fortunately, only 2 to 4% of people in the world have are homozygous for epsilon 4. I looked at some literature from India. Interestingly, in India, the prevalence of epsilon 4 genotype is around 0.15%, way lower than in the Western populations. Uh, and then if you have epsilon 2 genotype, that reduces the risk of Alzheimer's disease. But again, the prevalence of epsilon 2 genotype is also very low, unfortunately. Now, how do we evaluate Alzheimer's disease? So I want you guys to think about some of these questionnaires that you may already be familiar with, which is mini mental status exam, commonly used in the clinics. And there is a Hindi version also, which can be used for people with low education. And then we can also use MOCA, because MOCA is actually a more sensitive test. A lot of people, even when they have dementia, they may do well on mini mental exam because it's pretty simple. But MOCA is a little bit more difficult, and also MOCA is designed to assess even executive dysfunction, which mini mental status exam may miss. And fortunately, MOCA has been validated in Hindi language as well recently. So something to remember. Another thing which I also want to highlight is when you guys do MOCA exam, and when you're doing the delayed recall part in the exam, always give patients cues when they are not able to freely recall those 5 words that you give them, because that will tell you whether patient was able to store the words or not. Because people may be able to store the words, but they may not be able to recall them. So giving them cues will tell you whether the problem is of storage or of recall. Because Alzheimer's disease is characterized by problems with storage. Recall problems are also present, but storage is the hallmark of Alzheimer's disease. Storage disease problem is the hallmark of Alzheimer's disease. Now, recently, ICMR, in collaboration with 7 big academic centers in India, including AIIMS New Delhi, NIMS in Hyderabad, Apollo Hospital in Calcutta, Manipal in Bangalore, and JNMC in Karnataka, they devised this neuropsychological test battery called Mudra, which it's available in 5 Indian languages, including Hindi, and it's freely available. And it has a good sensitivity, specificity to diagnose Alzheimer's disease. Its sensitivity ranges from, I think, 70 to 100%, and similarly specificity as well. And it's also highly sensitive, specific to diagnose MCI as well. So something to look into. And then what does this toolbox comprise? It has tests of cognition. So tests to assess executive dysfunction using trail making test, and then category fluency, where you assess for semantic fluency by asking the patient to name as many animals as possible in 1 minute. And then the cutoff here is 11. And then the memory tests, and then there are visual spatial skill test, and there is language test using picture naming test. In Brigham, we use Boston naming test for that. And then it also has scales to measure depression, which is a very common finding in Alzheimer's disease, scales to measure instrumental activities of daily living, which are very important to monitor neuropsychiatric inventory, and then questionnaire for caregivers for an objective assessment of cognitive decline, and a short form health surveys to assess for general physical well-being of the patients. Now, this is an algorithm that we use at Brigham to evaluate Alzheimer's disease. So the most important task that one needs to do is obtain a detailed history of the patients, and then do a thorough neurological exam, something which psychiatry residents and psychiatrists often shy away from, and do a good mental status exam, which we are all pretty comfortable with, I guess. And also assess for instrumental activities of daily living and ADLs. And then always do a bedside cognitive testing, which doesn't take more than 5 minutes. And if you don't have that time, you can always refer the patient for a detailed neuropsychological testing. Or if you if the findings are normal on bedside testing, but you suspect the patient may have dementia, you should still refer them to a neuropsychologist or a psychologist trained in conducting neuropsychological testing. And always rule out reversible causes, causes of reversible cognitive decline, including thyroid tests, doing thyroid tests, vitamin B12 levels, sometimes B1 levels if the patient has a history of alcohol use disorder, doing an HIV test and test for syphilis, and always obtain an imaging. It could be CT head or it could be an MRI. But if you are doing an MRI, always obtain coronal cuts because they will best tell you the status of hippocampus. You want to rule out any structural lesions causing cognitive impairment other than the neurodegenerative disease. And you also want to look at specific patterns of various neurodegenerative diseases, some of which I mentioned earlier. And if the structural neuroimaging is normal, you can think about ordering a PET scan or an amyloid PET, which again, I don't think it's available in India. Even in the US, it is super expensive. Or you can obtain CSF biomarkers, which again may not be available in India, but are very useful if you can get them. They are highly sensitive and specific for Alzheimer's disease. Now, at Brigham and Women's Hospital, we use a four-tiered approach to formulate any given case of dementia or anyone who comes with cognitive problems. So we first think of what kind of syndrome the patient is presenting with. Is it amnestic? Is it language-based? Is it dysexecutive? Is it visuospatial? And then we try to see at what stage of the disease they are. Is it MCI? Is it subjective cognitive decline concerns? Is it early dementia? Mild dementia? Is it moderate dementia? Is it severe dementia? And then we try to predict what could be the underlying neuropathology. Is it Alzheimer's disease or is it dementia with Lewy body? Is it vascular disease? Is it frontotemporal dementia? Is it Parkinson's disease or Huntington's disease? And then we also try to assess for any factors which can be causing additional cognitive dysfunction. The most common things that we see are visual dysfunction because patient may have cataract, they are not able to see well, they may have hearing deficits, which are very common in old age. They may be using certain medications impairing their cognition, or they may be using certain drugs of abuse like alcohol or marijuana, cannabis. So you want to optimize all that. And those things are easy actually. And then what are the mimics of Alzheimer's disease? So other neurodegenerative diseases like dementia with Lewy body, vascular dementia, frontotemporal dementia can be a mimic. Certain psychiatric illnesses like depression, which can present with pseudodementia, psychosis when patient has a lot of negative symptoms, functional cognitive disorder, which is a type of dissociative disorder, substance use disorders, strokes, CADASIL, which is cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy. It's a familial disease which causes strokes, cognitive impairment, migraines, and psychiatric symptoms. And then certain brain tumors can mimic Alzheimer's disease, chronic traumatic encephalopathy, certain infections like HIV, heavy metal poisoning, which again is not very common, it's very rare. So you need to have high index of suspicion for that. Nutritional deficiencies may be common causes in Indian setting. Certain medications like sedatives, anticholinergic drugs, chemotherapeutic agents in cancer patients or in patients with autoimmune diseases, and then CNS irradiation can cause cognitive deficits. And then I want to give you guys a flavor of how it looks like, how this disease looks like in the clinic. So let's talk about certain cases. There was first case is a 60-year-old right-handed man who came to behavioral neurology for an evaluation, had a history of cognitive decline, behavioral symptoms for 2 years. His chief complaint was my memory is bad, which means he had good insight into his symptoms. He was experiencing memory loss, had difficulty recalling information about his life, had difficulty remembering new information, had difficulty expressing himself in conversations, difficulty finding right words, had slow speech. He stopped driving recently. He was having difficulty repairing doing repairs around his house, something he was very good at earlier. Now he needed reminders to take his medications. His wife had started to manage his appointments because he would forget them. And he was having a lot of depressive symptoms for the last 1 year. And then the last 3 months, he was having psychotic symptoms as well, in which he believed that his son-in-law and his wife's gay friend were hitting on her. And he had been trialed on multiple antipsychotic and stimulant medications before he came to us, which indicates how difficult it may be for psychiatrists to identify Alzheimer's disease if they are not well aware of it. And he had hypertension, hyperthyroidism, which were well controlled. He also had autism spectrum disorder, which was weirdly diagnosed in his 30s. Generally, people get this diagnosis very early in their life. And there was no family history of any psychiatric illness or dementia. And he had double bachelor's degree, so he was like well educated, but was on disability for 17 years for unclear reasons. And he was not using any substances. On mental status exam, he was apathetic, had constricted affect. His eye contact was poor. He had a lot of psychomotor retardation, slow speech, had delusion of persecution. Neurological exam was non-localizing. He was very slow overall. So, and also had difficulty learning the alternative movement test, which we do for assessing cerebellar functioning, and had slow finger taps, but no rigidity on the examination. On the MOCA, he did really bad. He got only 14, and he lost points on clock draw, cube draw, on digit span, letter tapping, which is test of sustained attention. He couldn't do serial 7 despite having double bachelor's degree. His phonemic fluency, which is tested by asking patients to tell F words, all the words which start with the letter F, as many as they can in 1 minute. He could only produce 7 words. And he did very poorly on abstraction test. His orientation was also impaired. And he could not encode even 1 word out of 5 on the 2 trials. And he could not recall any of them despite giving cues. And he could name only 4 animals in 60 seconds and started saying F words in between. And then labs were negative for any reversible causes. So at that time, since he was so depressed, we thought that maybe his cognitive decline is because of the depression. So we wanted to treat that first before giving him a diagnosis of Alzheimer's disease or any dementia for that matter. So we obtained an MRI which showed like this. So you can see in these sagittal, axial, and coronal cuts that there is, bilateral hippocampal volume loss. You can see these black spaces here in the third image. And he also had bilateral frontal and parietal volume loss as well, which can be seen when the disease progresses. But still, we wanted to be very sure of our diagnosis. So we did CSF biomarkers, and he had reduced A beta 42 protein in his CSF and increased total tau and phosphorylated tau. All these 3 are highly suggestive of Alzheimer's disease. These are hallmarks of Alzheimer's disease on CSF. So with this, we were able to give him a diagnosis of Alzheimer's disease despite prominent depressive symptoms. And based on our 4-tier approach that I talked about earlier, we can formulate this patient syndrome as a monastic with language involvement. His stage was mild dementia because he lost some IADLs, although he also had difficulty with ADLs, but it wasn't very clear to us whether it was because of Alzheimer's or because of depression. And his neuropathology was highly suggestive of Alzheimer's disease because of typical hippocampal volume loss and because CSF biomarkers were consistent with that. And additional factors which were impacting his cognition were probably depression and autism spectrum disorder. Now, the next case, a 76-year-old right-handed woman came to us for second opinion. She was already given a diagnosis of dementia, and her symptoms were going on for 4 or 5 years. Her chief complaint was, I don't know why I'm here, which means she did not have any insight into her symptoms. And her family said that she was forgetting things quickly. She had poor concentration. She had word finding difficulties, had difficulty recalling names of her family members, could not sometimes even recognize them, had difficulty using gadgets at home, including dishwasher, using her cell phone, TV remote control, had difficulty remembering names of her medications and taking them. So her husband started supervising. She had difficulty with cooking. She would forget the recipes. So her husband took over that role as well and started managing finances also for her. And then she would forget what she needed to buy when she would go to the store. She stopped driving her car on her family's insistence because they didn't want to take any chances with her. She remained independent of her ADLs, and she also had difficulty with identifying strangers on the street. She would think that she has already seen them before or knows them, and sometimes she would confuse any young kid with her grandson. And she used to be a great painter, according to her family, but she stopped painting 10 years ago, which suggests that maybe she developed apathy long ago before the onset of these behavioral and cognitive symptoms. And her sleep was fine. You want to always rule out any sleep disorders because they can also cause cognitive changes, especially obstructive sleep apnea in Indian setting, where people think that snoring is fine uh, and it doesn't need to be addressed. And she was very healthy, only had osteoporosis for which she was on treatment. She didn't have any psychiatric illness in the past. She did have family history of Alzheimer's disease in her mother and aunt, but it was late onset, so probably not genetic uh, underpinnings here. She drank only 1 glass of wine daily. She was a trained nurse and had a diploma in computer science. And she also owned a business of her own. And she retired 10 years ago. Her mental state exam was absolutely fine, except for limited insight into her deficits. Her neurological exam was non-localizing, had mild but intention tremor bilaterally, and labs were normal. On MOCA, she also did terribly. And she was able to encode all the 5 words, but could not recall any of them spontaneously. But she was able to recall 2 with cues, which highlights storage problem, uh, something which is seen in Alzheimer's disease. On the semantic fluency, she did really bad. On the Boston naming test, which which can also be impaired in Alzheimer's disease, she got only 5 out of 15. And then we were suspecting some other possibilities in her case, including frontotemporal dementia, semantic variant. So I did some more testing, and she was able to do all that well. Now let's look at her MRI. So in her case, you can see her hippocampi are not as atrophied as the previous patients, but her anterior temporal lobes here in this axial sequence, axial cuts, are very atrophied as compared to the rest of the brain, which seems full. And she had mild bilateral frontal atrophy as well. So the imaging is not typical of Alzheimer's disease here, but the clinical syndrome is, right? And as a result, we are considering a second possibility of semantic variant frontotemporal dementia in this case, because she did really bad on picture Boston naming test, and it seemed as if she had lost the knowledge of what those pictures mean despite giving cues. So we'll be working her further to see whether she has Alzheimer's or semantic variant frontotemporal dementia. Now, how do we manage this disease? So the principles of management are to devise strategies to prevent any neuropsychiatric symptoms from emerging, or treat them if they occur, and use non-pharmacological treatments first instead of using medications, because medications can have a lot of side effects in old people. Unless there is an emergency, you should stay away from them. And you also want to increase patients and caregivers safety, because people with Alzheimer's disease or other dementias can put themselves at risk by their behaviors and cognitive deficits. And you want to reduce distress in the patient and the caregivers. You want to reduce the need for hospitalization, because that can be very expensive. So non-pharmacological approach involves risk assessment. You want to see if they are fit to drive. You want to assess them for any false risk, financial risk, because these patients often become victims of fraud, and they may lose their life savings with that. You want to assess them for any fire hazard. If they're cooking and they forget to turn off the stove, that can be a big problem. You want to see if they're taking their medications on time in the specified amounts, if their nutrition is fine, if they're if they are victims of abuse or not, because that's very common everywhere, including in India. You want to psychoeducate them and their families. You want to manage the caregiver burden, connect them with community resources. You can use physical activity like simple walking, music therapy, art therapy, light therapy to control their behavioral problems, psychotherapy for depression and anxiety, cognitive retraining, which can help with some of the cognitive deficits on a temporary basis. And you can think of sending them to day programs where they can get social stimulation, and should always talk about advanced directives and end of life care with them, because this disease is going to progress. And then placement, long-term placement, where they will be living when their symptoms become really bad. And genetic counseling only in case of patients who have autosomal dominant early onset Alzheimer's disease. And then how do we treat it with medications? No disease modifying therapies are available till date. Almost all drug trials targeting amyloid beta have failed till date. FDA recently approved a drug called aducanumab, which cost $45,000 for 1 year recently in June, but its efficacy is also very controversial. And we are not using it at Brigham and Women's Hospital. And then people use donepezil, rivastigmine for mild to moderate Alzheimer's disease, dementia, and memantine for moderate to severe disease, which can give patients some cognitive boost, but it doesn't really change the trajectory of the illness. And there are no FDA-approved medications to treat neuropsychiatric symptoms. Depression, anxiety may require antidepressants, for which you may use SSRIs. Agitation and psychosis can also respond to citalopram based on RCT. So you can avoid using antipsychotics if you want to, because there is an FDA black box warning on all antipsychotics because they increase risk of stroke and death. And apathy may respond to stimulants, but you need to be careful with that because stimulants can cause high blood pressure and stroke. And insomnia can respond to trazodone and melatonin, which are generally safe. Then future directions. We want to create awareness among people, among psychiatrists, other doctors, and advocacy on our part for the government to spend more money on treatments and research, and for providing services to patients and the families. Epidemiological studies need to be undertaken in India. There aren't many like pan-India studies which have been done. And then histopathological, molecular imaging, genetic studies are required to inform drug discovery, and ongoing efforts to find effective drugs to modify disease and for neuropsychiatric symptoms are very important. And longitudinal studies are required to ascertain the prognosis of this disease and see how this disease evolves in different populations, because those studies are lacking in developing countries. Now, take-home points. It's the most common cause of dementia. It's highly prevalent yet very underdiagnosed. Amnestic presentation is most common, but then there are 3 other non-amnestic presentations as well, which we need to be mindful of. Neuropsychiatric symptoms are core features, and they increase the risk of cognitive decline independently and cause caregiver burden. And biomarkers have gained significant prominence in its workup. However, the diagnosis remains clinical till date. So you may save some money for your patients by being clinically sound. And there is no role of ApoE genotyping, even though it increases the risk, because it's very uncommon in population. And mixed neuropathology in Alzheimer's disease is the rule rather than exception. No disease-modifying treatments are available. Management focuses on some symptom prevention, treatment of the symptoms, and caregiver relief, and use non-pharmacological treatments first, followed by medications in that order. And thank you so much for your active participation. And I'm very happy to take any questions or any queries that you may have. I'm happy to explain. And you can also reach out to me through my email, or you can send me a message on Twitter if you are comfortable with that.
Thank you very much, sir. So we have a question in the chat box by Dr. Hers. Is there a role for preventive strategies such as control of hypertension and mental exercises in Alzheimer's, as recent studies suggest?
Right, great question. Thanks so much for asking. So Lancet Commission believes that 40% of dementia in the world can be prevented by optimizing, vascular risk factors and other healthy lifestyle interventions. However, it's not well known whether Alzheimer's disease per se can be prevented. But there is a possibility that you may delay the onset by controlling hypertension. Regarding mental exercises, there isn't any strong evidence to suggest that it will slow down the progression or reduce the risk of Alzheimer's disease.
Thank you, sir. Anyone else? Any other questions? Residents?
Hello, I have a question, ma'am, actually.
Yeah, sir.
Ma'am, as far as in DSM-5, ma'am, they've changed from 2 cognitive domains to diagnose dementia to 1 cognitive domain for dementia. So, but sir told us about the diagnostic criteria that still includes 2. So, shall we include 2 components?
Right. So basically, these criteria that I mentioned, they came in 2011, right? After National Institute on Aging work group meeting. So we use these in behavioral neurology and neuropsychiatry instead of DSM-5 criteria. And the sensitivity specificity of using this approach is up to like 80 to 90%. So you can be certain at that number using this approach.
Okay, sir. Thank you so much.
Preeti ma'am?
Yeah, yes, Anushka, go ahead.
Yeah, sir, a very good lecture. Thank you so much. I had a query, sir. Sir, what is the approximate incidence of seizure in patients with Alzheimer's? This is something that I was not aware of. And what could be the possible neurobiological cause of the seizure? Could it be contributed by the mesial temporal atrophy that you mentioned?
So that's a great question. The seizure prevalence is like it differs in different studies, right? And it also depends on the stage where you are detecting the seizures. As the disease advances, the risk of seizures increases further. So if so there was a study at Mass General Hospital at which is a allied hospital of Brigham a couple years ago, where they found that the prevalence of seizures in those patients was around I think 5 to 6% after I think after six years of the onset of the disease. Often these seizures go undetected because they may not be generalized tonic-clonic seizures. They may be just focal seizures, where patients are just staring into the space for like a few seconds, and the family may not be able to pick on that. The patient may not even be able to tell you because of the language and the cognitive problems. So you need to have high index of suspicion for that.
Sir, I had one more query. So regarding the subjective cognitive impairment, is this only, for research purpose, or can we actually use this in the clinical settings? Because sometimes people in their late 40s and 50s come to us with complaints of memory problems, and we tend to either dismiss them or we tend to contribute it to depression, which is the first thing that comes to our mind. So is there a way to delineate that this could be an indicator of something else?
That's a wonderful question. And actually 40s is the age when most people present with subjective cognitive symptoms in the clinic. So one should never dismiss them, should always investigate. And I mean, as you already said, depression and anxiety are one of the most common reasons for those subjective cognitive concerns, but they may not be present in every case, right? So some people may actually have the onset of Alzheimer's disease at that time. Now, there is a huge debate in this field on what to do with those patients. Should we do an MRI, because MRI may not even be abnormal at that time. Then the next step could be whether we want to do CSF AD biomarkers in them. And if you obtain AD biomarkers and if they come back positive, how are you going to counsel those patients? What will you tell them? Okay, you have Alzheimer's disease in your brain, and it could be devastating for a patient at the age of 40 to know that they have Alzheimer's disease, right? So at this time in clinical and research world, there is no consensus on what to do, but you definitely want to monitor them closely for further evolution of those symptoms, and should not just dismiss them at their face value.
And how to manage those patients? How to, like, we had some patients who had been presenting predominantly with memory impairment in the late
Right.
40s,
Right.
but with no psychiatric symptoms other than the
Mhm.
memory impairment. So how to manage them? We are not giving them any pharmacology. Non-pharmacologically, what can we do?
Right. So what we do here is, first of all, we always obtain an objective evidence of that impairment, because oftentimes patients may say that okay, they have an impairment, but we don't know whether it actually is happening or not, right? It could be just subjective. So you want to establish that this is not MCI, right? And that can only be done by doing an objective cognitive testing. So doing that, and then after that, doing a workup for other medical causes. Oftentimes in India, anemia is very common, which can cause memory problems, attention concentration problems. And often actually it is the attention problem which present with memory problems, because they are not able to encode. So they think that they are forgetting, but actually they never learned that information. And then ADHD is another very common thing which often gets missed uh, in childhood, because teachers are not paying attention, or they may not be aware of, families may not be aware of. And ADHD, with the more and more stress in the life, and when responsibilities increase, the disease it manifests itself later in the life, especially the inattention component of ADHD. That could be one factor. Then other medical conditions like hypothyroidism is very common, right? I think it's present in around 10% of people, general population. So optimizing that, things like obesity, obstructive sleep apnea, insomnia, diabetes, these all can also cause cognitive symptoms, attention problems. So you want to address those as well. And finally, you can always send the patient for cognitive rehabilitation if those services are available. And these days, even computerized cognitive retraining is available. Although, I mean, they will have to pay for that. It's not free, but it's an option these days.
Thank you, sir. Dr. Surendra has posted a question. Is there any good book or study material on behavioral management methods in dementia?
Good book. So we have, I mean, we
Or
have
study material, I'm sorry, or study material, he has asked.
all study material. I mean, you can, easily read about that in any paper which published in a good journal, like a review of Alzheimer's disease management in Lancet or NEJM or Nature Neurology review. Those are very good sources for this. In terms of books, I'm pretty sure there is a lot of literature available on Alzheimer's disease, its biomarkers, its treatments. I can't think of anything off the top of my head in terms of books, because I generally read the articles, not books. But I can send you some. So you can feel free to send me an email, and I can recommend some books and some articles that would be helpful.
Yeah, that would be great, sir. Thank you.
And I think I missed one of the questions. Somebody asked, what is the neurobiology of seizures in Alzheimer's disease? So that's not because of mesial temporal atrophy. It's actually because of the scar tissue that develops, right? Because of the neuroinflammation in the brain, which can cause gliosis. That can increase the risk of seizures. Okay. Anybody else who has any questions?
So there's a last question by Mrs. Lakshmi. She has asked what memory techniques can be used in Alzheimer's patients?
I'm sorry, memory techniques?
Memory improvement techniques.
Memory improvement techniques. So I think one thing which needs to be emphasized is rehearsal. So you want to repeat, just like we do in automatically while in school, we revise, right? Secondly, try not to do multitasking, because we are not good at multitasking. Human beings, especially men as opposed to women, are not good at multitasking. So when you are doing something, learning something, you should focus only on one thing and take adequate breaks, because interval when you take breaks, memory consolidation happens at that time, and adequate sleep is very important for any kind of learning. And then you can use multiple sensory modalities to learn something. So for example, if you want to read a chapter, right, you can take down notes, so you're using your muscle memory there. You can speak while reading, so that will use your auditory cortex for that. And then you can use videos after whatever you have read to revise things. That will stimulate your visual cortex. So multi-sensory modalities to learn anything is more helpful than using one modality.
So actually, the question was specific in patients with Alzheimer's dementia. In them, what are the techniques you can say that on non-pharmacological techniques to improve their memory?
Right. So as I said, so memory actually may not really improve. I mean, because the disease is running its course, the patient is losing neurons. You can give them a boost temporarily for a few months with cognitive retraining, using the same principles actually that you would use for anybody who does not have dementia.
Yeah, thank you, sir. I think due to paucity of time, the other questions we can mail you, or we can send you through the chat, WhatsApp chat. So thank you very much for such a comprehensive presentation and giving us your time. I request Dr. Naresh for his remarks.
Thank you very much, Dr. Rishab Gupta, because many of the things were very much clinically oriented, and yes, all of us were pretty engaged. Most of us could not even distract for seconds even, I must say. And again, many things were new for all of us, and I also learned many things. I'm just picking two statements from your concluding slide. One was we need to have clinical skills to timely diagnose as well as address these problems, because I'm sorry to say these things are going out of hands of psychiatrists. Right. This I learned 5 years before in one of the national geriatric psychiatry conference in the presidential address. But again, this trend we are also seeing in last 3-4 years, very less number of dementia patients we have in our clinics. And where are they going? Obviously neurologist or physician. Right. Not the prevalence is reducing. So our residents and many people have seen very less number of cases. So that's why we need to have advocacy. Because yes, it's a multidisciplinary approach works rather than only neurologist or physician. Right. So mental health professionals are equally important, and we need to have hands-on with our own strategies as well as these discussions. And thank you very much. And again, we'll have more and more interactions from your side at your convenient time with coordination from Dr. Preeti.
It would be a real pleasure to be back.
Same from our side. And on behalf of the department, thank you so very much. And over to you for your concluding remarks. And thanks to Dr. Preeti as well. Thank you.
Right. So I really hope that you all enjoyed this talk and learned something from it. Even if you can remember the take-home points, I think that would be justice to this 1 hour that we spent together. And I want to thank you all for taking your time on this early Saturday morning, which we in the US we hate to wake up at this hour on a Saturday. So I really thank you all for being very attentive, for asking great questions, and for being active participants. A lot of times, with Zoom, a lot of people they just switch off their camera and then they mute themselves, and then they wander off when a talk is going on. So I really appreciate that, and I want to express my thanks to Dr. Kadiresan and Dr. Nabinani for making this possible and for giving me this platform to talk about Alzheimer's disease, which is something I'm really passionate about. And I think we all should know. And on heels of what you said, Dr. Nabinani, I think psychiatrists among all clinicians are best placed to actually manage Alzheimer's disease, because it's like other clinicians are not really well versed with communication skills to interact with patients and with those distressed families, which is extremely important aspect of Alzheimer's disease care.
Very true, sir.
Thank you very much, sir.
All right.
So with this, I think I will conclude. Thank you
All right.
all for your active participation.